known as shaken baby syndrome. An important guidelines from the Royal College is set on this topic. Shaken baby syndrome presents as retinal haemorrhages and cotton wool spots in an abused infant. So it might happen after shaking the baby, just gentle shaking. The problem with the baby is the main size and weight is in the head, which makes it very prone to trauma, cerebral trauma and ocular trauma. So in the eye, there are hemorrhages and cotton wool spots, which makes it very similar to Terson syndrome, Purchase retinopathy, and central retinal vein occlusion. Let's first start discussing the clinical picture of abusive head trauma. It's mainly retinal hemorrhages. It might happen in any layer, just like Terson syndrome. Might be pre-retinal, might be sub-ILM, and this is very famous. It causes what's called a hemorrhagic macular cyst. Retinal hemorrhages are common in the periphery and in the posterior pole. There is also secondary retinoschisis, because when there is a bleed in between under the sub-eye limb or in between the retinal layers, this might end up by causing splitting of the layers of the retina, which we call retinoschisis. Secondary retinoschisis in middle-aged age group might be secondary to intermediate uveitis. In old age group, this is degenerative retinoschisis, and this is not secondary, but these are the causes of retinoschisis. The X-linked retinoschisis, myopic foveoschisis, and shaken baby syndrome or abusive head trauma retinopathy. All these lead to secondary retinoschisis in the fovea, in the posterior pole. Myopic foveoschisis usually takes place in middle age group. X-linked is beyond the toddler age, and shaken baby syndrome is very young baby. So by using a RetCam handheld OCT, there is foveoschisis. There are also signs of vitreous hemorrhage and papilledema. And this is important because papilledema might present with hemorrhages. Bear in mind that papilledema happens in 95% of cases with increased intracranial tension. So 5% of cases present without papilledema, but hemorrhage cannot happen without optic nerve head swelling. Anterior segment findings are usually not characteristic, and this is usually secondary to CNS injury. Things like anisocoria, poor pupillary reaction, mydriasis, these are usually secondary to CNS insult. Central lesions in abusive head trauma, subdural or subarachnoid hemorrhage, cerebral contusion, hypoxic ischemic brain injury, skeletal or cutaneous injuries. And this makes sense because cerebral injury is the most common reason for visual loss in these patients. Besides, the initial presentation might be from cerebral infarction. So, ophthalmic examination in a child with cerebral infarction, if it reveals hemorrhage, you need to differentiate it from Terson syndrome and abusive head trauma. I'm saying that because ocular injury is present in up to 30 to 40% of abused children. But 75% of these children with ocular manifestations show brain injury, which means that the ophthalmologist might be the first clinician to see the child. The role of the ophthalmologist in abusive head trauma is diagnosis. We aid in diagnosis, but we don't manage these cases. But we need to have high suspicion to alert the pediatrician, to alert the other doctors that we are suspecting something wrong happening. Bear in mind that retinal hemorrhages can happen after normal, uneventful vaginal or cesarean delivery. This happens in 1/3 of the newborns and usually resolves by around 1 month. So this needs to be on our differential diagnosis. Differential diagnosis of abusive head trauma is Terson syndrome, vitreous, preretinal, retinal hemorrhage associated with subarachnoid hemorrhage, Purchase retinopathy, and central retinal vein occlusion. In fact, central retinal vein occlusion in infants below 1 year of age is quite rare. It might happen due to systemic causes like thrombocytosis, like polycythemia, inflammatory conditions affecting the endothelium of the blood vessels, might happen due to orbital compressive lesions. And this is a viva question here. So if a 6-month or 4-month child presents with central retinal vein occlusion, normal systemic evaluation, what's your next step? Orbital examination for possible compressive lesion. Consider MRI, CT scan. These children carry a poor prognosis, usually because of the sequelae of intracranial injuries. In the eye, there might be macular scarring, vitreous hemorrhage with subsequent tractional bands, retinal detachment, amblyopia. So this is a second cause of visual loss in these children. Number 1 is central nervous system insult. Number 2 is deprivation amblyopia. These children might also develop macular holes. This photo is not of abusive head trauma retinopathy. Subhyaloid hemorrhage causes hemorrhagic macular cyst, and here is something that I didn't mention, the circular perimacular folds. You might see a patient with chorioretinal folds. Usually, they're just concentric to the fovea. This might indicate an old abusive head trauma. In Terson syndrome, there are chorioretinal folds as well, but they are radial, radiating from the optic nerve. And in Terson syndrome, they are extramacular, they are sparing the macula, in contrast to the abusive head trauma, which involves the macula and fovea. Late changes are usually non-specific, with CNS amblyopia affecting vision, optic disc pallor, optic atrophy, non-specific retinal pigmentary changes, macular hole, vitreous opacities, retinal thinning, and high myopia. I advise that you can read the Royal